behalf of Looping, I, Jayesh Makwana, Group Product Manager, welcome you all for our today's roundtable meet discussion on inside story of PPI. And for our today's discussion, we have invited renowned gastroenterologist of Tamil Nadu, Dr. Arun N. Dr. Arun N has more than 6 years of experience in this specialization of gastroenterology, and currently he is a consultant gastroenterologist, hepatologist, and interventional endoscopist at Apollo Hospital, Chennai. And he's also a director, Chandra Gastro Liver Clinic and Endoscopic Center, Chennai. So without taking much of the time, I would like to hand over the session to our today's speaker, Dr. Arun N. Over to you, sir.
Thank you, Jayesh from Lupin, who gave me a wonderful opportunity to be here to share some knowledge and inspects about what are the various things which is happening in proton pump inhibitors. And good evening, respected professors, senior consultants, and dear friends. It's really a great pleasure for me to meet you all to discuss in this wonderful evening about the basic molecule in which our daily life, our daily routines won't be complete without this proton pump inhibitors. We are going to look into that right from physicians, surgeons, even from the general practitioners, even the pharmacists who have been prescribing this kind of prescriptions. Without this molecule, no prescriptions will be going outside any boundaries. So why I would like to state that, so if you're going to use this PPI for a longer duration of time, what are the various impact it's going to create? That's the main area for me to discuss with you all in this forum right now. See, if you're going to use PPI for a longer duration of time, what is going to happen? This is briefly about my disclosure. So this, I will be starting you with a discussion about the basic drug interactions, various adverse events, what are the various impact in which this PPI is going to create in your daily routines for a patient who's going to have a long-term significant impact. What is the day? I mean, in what way it's going to affect the patient's clinical adverse events. That's what the main aim for me to take on the discussion. So regarding this case scenario for a 50-year-old man who presented to us in the emergency department, he came unconscious after a brief dinner, followed since the patient was having a long-standing diabetic mellitus. If you're going to look into that, the patient is going to be on OHA, sulfonylurea, for a longer duration of time. But when the patient was tested, the patient shows evidence of hypoglycemia, but HbA1c was normal. So the patient recovered after IV glucose solution, and followed by this patient has come to conclusion that this patient is having a drug interaction because of PPI. Because as you all know that PPI is having a huge metabolic pathway based upon the various molecules what you're going to use. So various interactions going to be on. So don't think that if you're going to use PPI, it doesn't going to harm the patient. There are many case reports throughout the journals, even American Heart Association, even Nephro Association, everyone been approved that there are significant impact with your PPI if you're going to use for your daily routines. So why would to show this case scenario with you all? Because if you're going to use PPI for a longer duration, there might be a various drug interaction which can happen because of this event. So what are the various discussion right now in the forum? Briefly, see, this is a brief area. It's a one-to-one discussion, nothing more complex, nothing much to hide, and it's very simple phenomena to understand. So basics of PPI, the metabolism, how the pharmacology and mechanism of action, and next to that, what are the various drug interactions, in which way it's going to interact with the drugs, and followed by what are the various adverse events it can cause, followed by its brief summary and conclusion what we are going to discuss with you all. So if you're going to look into this huge armamentarium of use of PPI, there are multiple areas you are going to use this PPI in the field of gastroenterology. First thing, as we all well know, the reflux is a fasciitis. It could be erosive or non-erosive reflux. That's a separate area for me to discuss. And apart from that, there are multiple other uses for dyspepsia, even for functional dyspepsia, functional GI disorders. And if you are going to use for example, for Zollinger-Ellison, in which if you have gastric secretion, it is going to be too high, so many stress-induced gastritis, drug-induced gastritis, NSAIDs, so many indications are there for you to consider PPI on your daily basis. So how long you are going to subject the patient based upon your clinical parameter, based upon the clinical indication. And once you subject the patient with PPI, how are you going to monitor in case if the patient is elderly male, in case if the patient is pregnant, in case if the patient has multiple other coexisting comorbidity like type 2 diabetes, hypertension, a coexisting metabolic syndrome, or in the background of kidney disease, or in the background of renal injury, or if you're going to suspect your electrolyte imbalance, or if the patient is going to be in ICU care, or in the background of septicemia. This is how we need to approach a patient when you're going to subject the patient with PPI. So why I'm implicating all those things, you should know the various drug interaction. That's the main area for me to take on the discussion with you all right now. So defining GERD, very simplex. If you're refluxate, if your gastric contents, if it is going to get refluxed into your esophagus, nothing but a GERD sets in. Apart from that, the refluxate could be because of content acid, pepsin, bile, or so many other things will be there. And if your refluxate mechanism, if it fails to implicate properly, there might be having a worsening of reflux phenomena. So once a patient is going to have a reflux disease, so what is the problem? What is the primary line of modality? We are going to subject nothing but a proton pump inhibitor. So what does this proton pump inhibitor? It's nothing but an integral membrane proteins, which is going to predominantly locate in the parietal cells. So in this, what is the role of PPI? It's going to block your hydrogen potassium ATPase. So what is this? So it's going to irreversibly block your hydrogen potassium ATPase in your parietal cell. I'll be checking on that discussion with you now. And see, if you're going to look into this, see, it suppresses the gastric acid secretion, as I discussed, by inhibiting the hydrogen potassium ATPase in the gastric pathway. Apart from that, it's also acting specifically on the proton pump. It blocks the final step of your acid production. See, if you're going to look into this, I will be showing a brief diagram about how to understand this hydrogen chloride acid secretion. See, if you're going to look into the stomach, there are multiple cells are there, chief cell, histamine secreting cells, so many others, G cells, so many cells are there, more than 5 cells are there to involve in the secretion of various pathways. But when you're going to look into this hydrogen chloride HCl secretion, which is from your blood side to your gastric lumen, so what is going to happen by formation of HCO3 from carbonic anhydrase, which is going to involve, so what is going to form? So once the hydrogen ion is going to get accumulated in your gastric lumen, along with it will be going to convert the potassium ion into your parietal cell. So your hydrogen ion, once it's going to get accumulated into your gastric lumen, the gastric acidity is going to get increased, followed by the proton pump. It's going to say only in the terminal stage, this proton pump is going to get released. And there are so many molecules being targeted if we are going to look into this pathway. So one is by CAM-dependent pathway, one is by calcium-dependent pathway, one is, see, what is going to happen? It's going to irreversibly block. The main thing, it replaces a non-acidic potassium ion, and it will be predominantly, for example, if you're going to take omeprazole, it is going to be a prodrug, which is going to get activated in your acid environment. So once it gets absorbed, the active metabolites, which will going to get diffused into your parietal cells and accumulate in your acid secreting canaliculi. So this is nothing but which is going to get accumulated in the acid secreting canaliculi. What is going to happen when you're going to consume your food? The acid secretion and acid secretion activity, everything is going to get high, followed by what is going to happen? The inactivated form of PPI gets converted to a activated form, which is nothing but a sulfonamide derivative in your acidic secreting canaliculi of your parietal cell. So once a sulfonamide moiety, if it is going to get formed, if you are many things have not been shown in this diagram. You should understand the prodrug is going to get converted to a sulfonamide moiety. So what is going to get happen? The lipophilic to lipogenic forms is going to get converted, and followed by the acidic environment is going to get released and neutralized. The protonation is going to get set in, and that's how hydrogen potassium ATPase pathway, the inhibition of hydrogen, which is going to happen in the terminal area of your parietal cells, terminal area of acid secretion. That's the main area to concentrate with you all right now. So it's mainly interact by covalently binding with your various sulfhydryl groups, and thereby it's going to irreversibly block this hydrogen potassium ATPase. That's how we need to understand, because there are so much of triggers in this acid secretion. One is by histamine receptors, and apart from that, this is by histamine receptors, and also by CAM-dependent pathway, calcium pathway. There are so many other things which is going to accumulate a HCl, which will predispose to acid secretion, and we are going to subject the patient with PPI. it's irreversibly going to inhibit for hydrogen potassium ATPase, and that's how it will take time for this irreversible inhibition. And once the patients, so if you're going to take a patient with PPI, this will be taking a minimal duration of around 4 to 8 hours for this basic mechanism to set in, followed by only then the irreversible acid secretion pathway is going to get blocked off, and then only your PPI effect is going to start on. So it will take time for the PPI to act when you're going to subject the patient with the longer duration of therapy. And this is all the hepatic metabolism of your PPI is going to get concerned. If you're going to look into this molecule, the metabolic pathway either by hepatic route or by renal route, as we are well know, hepatic metabolism will be a predominant form. And if you're going to look into that, it's mainly going converted to two active, enzymatic forms, one by CYP2C9, and there are multiple enzymatic derivatives are there, but always you try to remember this, because CYP2C19 and CYP3A4, which is the main area which is going to get focused in your hepatic metabolism by converting to your hydroxy metabolite and by converting into a sulfone metabolite. So most of the molecules will be, if you're going to look into the newer molecules like chenetoprazole or whatever the molecules, if you're going to focus, the main mechanism of infraction like this, followed by rabiprazole, there might be a significant difference in that. That's why sometimes if the patient is having major cardiovascular other things, even if you're going to set in, there might be having some beneficial effect if you're going to subject the patient with rabiprazole. But this is all the basic metabolism of your hepatic clearance of your PPI when you're going to set in the basic pathway. See, if you're going to look into this diagram, see, it'll be going to form a multiple metabolites. So omeprazole or esomeprazole, if you're going to look into this, it is going to convert it into its, by the omeprazole sulfide into its various derivatives. If you're going to look into lansoprazole by various derivatives, it's going to convert it to lansoprazole sulfone, and pantoprazole also by similar mechanism. But if you're going to look into rabiprazole, it's been significantly having a mild difference when we are looking into that, mainly by a non-enzymatic degradation pathway is going to get involved, followed by a rabiprazole sulfone component is going to get formed. That is why when you're going to subject the patient in various coexisting alarming symptoms, rabiprazole slightly having a hypotensive when compared to this kind of molecules, and means in educating the patient with major cardiovascular events. And this is how the PPI differences emerges in your hepatic metabolism pathway. See, the various molecules will be going to get metabolized through your CYP2C19. If you're going to look into this, for example, clomipramine, diazepam, so many molecules, and mainly all cardiovascular molecules like clopidogrel, warfarin, which is going to get involved in this pathway, and CYP3A4, also a huge list of molecules being there, and the metabolism is always being a less dependent pathway, and therefore it is not going to much affected by your polymorphism or genetic polymorphism when you're going to subject the patient with PPI for a duration of therapy. And so if you're going to consider the interactions of your PPI, it's mainly based upon,
okay.
Yeah, my voice is very clear, am I sure? Yes.
Yes,
so
sir.
if you're going to consider the interaction of your PPI, it's mainly based upon the patient clinical status and patient comorbidities and patient's duration of therapy, and to whom you subject this PPI, whether the patient is going to be elderly population, as we discussed with all the various complications, to whom you're going to subject the PPI. That is what the main mechanism, that's what the main area to concern for us when you're going to subject a patient with PPI. And this is what the basic thing you should remember, that polymorphism of CYP2C19 and therapeutic response to your PPI. What is mentioned that? So if you're going to give most of the molecules by genetic association has been found between the genetic polymorphism of CYP2C19 and the therapeutic response to PPI. So CYP2C19 occupies a varying frequency among different ethnic groups. So for example, for North Indians, it will be around 12%, and for South Indians, it will be around 14%. So there will be a various frequency of response in different ethnicity, but the polymorphism is one thing which is going to contribute to a drug metabolism pathway, which is going to have a significant impact in your population subgroups. So always you should remember the genetic polymorphism of CYP2C19 is going to have a significant impact, impact in your drug interaction pathway. So this is how then if you're going to look into the lunch and supper for omeprazole, lanzo, or rabiprazole, so if you're going to look in the intragastric pH profiles after subjecting the patient with for 8 days, so you can able to analyze this CYP2 status. So the, genotype status, if you see, if you're going to use this, nothing, if in rabiprazole, there is not much of variation apart from omez and lansoprazole, that shows some minimal variation of genetic polymorphism, which is going to be considered. So basically, what are the various conditions in which you need to be very cautious in you're going to subject the patient with PPI? That's been for me to take on now. So once the patient is going to have a significant kidney disease, if, for example, if the patient is having tubular interstitial nephritis, or if the patient is going to present with acute nephritis or chronic nephritis or glomerular injury, or in the background of acute kidney disease or in the background of chronic kidney disease. So this is what the study has been taken from a JAMA group. What I mentioned in this, the PPI use has been shown to have a significant impact in the risk of chronic kidney disease. So there is a huge list of PPIs that have been discussed. So lansoprazole, pantoprazole, huge list of PPI can be having a significant impact. But how this is going to have an impact, injury in your kidney, is still more studies need to be documented. Because what they've been mentioning in that, once you're going to subject the patient with PPI, there might be evidence of nephron loss and nephronic injury. If you're going to subject the patient for more than 8 to 12 weeks of therapy, at that point of junction, the background of multiple comorbidities, there is high possibility for this patient to develop a tubular interstitial nephritis. That can be very easily diagnosed based upon a clinical presentation, based upon your urine examination, a short course of fever, eosinophilia, rash, and other complications, along with your clinical urinary pointers. All those things can be taken to diagnose your interstitial nephritis. And what they've been mentioned in this presentation, what they've been taken from your JAMA group, if you're going to look into your PPI, that shows a significantly independent risk factor for more than 20 to 50% higher risk for this kind of patients to progress to chronic kidney disease. So once a patient is having evidence of chronic kidney disease, always, if you are going to look into the data, H2 blockers and PPI, the potency of H2 blockers in the inhibition of acid secretion will be around 50 to 60%. But when you're going to think about the PPI, the inhibition acid secretion will be around 80 to 90%, because PPI is even the well potent in maintaining this efficacy, but you should think when you're going to subject the PPI patient with PPI, it's better to go with hydrogen blockers rather than considering PPI in this kind of scenario when you're going to manage. So the risk was specific to PPI medications because the use of H2 receptor antagonists, which are prescribed for the same indication as PPI, was not independently associated with your CKD. So PPI use itself can be considered as an independent risk factor for CKD as well as your acute kidney injury. So be very cautious when you're going to subject, because there are no single effective trial to prove that. But some papers are being quoting that there might be not worsening of events in the background of interstitial nephritis, but there are many papers to support the evidence of interstitial nephritis, CKD, or acute kidney disease to progress in the background if you're going to use this patient, if you're going to subject the patient for PPI for a longer duration of therapy, if the patient is going to have evidence of chronic kidney disease. So apart from that, what is the role of the main area for me to take on this major acute cardiac events? So if that's nothing but MACE. If you're going to discuss about this MACE in role of PPI, what are the various studies, what they're going to discuss? If you're going to look into this paper from BMJ, what they'll be people who are going to take PPI for a longer duration have 16% chances of higher risk for this kind of patients to progress to myocardial infarction. Because it's very interesting. I'm going to show you an interesting slide how this patients with PPI is going to have significant impact, in which have been taken from a recent American Academy of Association Cardiac Journal. What they've been mentioning that once a patient is going to subject with the longer duration of PPI, that possibility, because you are going to use multiple molecules, blood thinners, and other things, platelet inhibitors, and all those things, if you're going to subject warfarin, clopidogrel, aspirin, and other molecules. So we are going to use, there might be evidence of drug interaction that I'll be discussing with you in my upcoming slides. So why I would like to point it out, so PPI associated with MI in general population, if you're going to look into this study, what they've been taking from, see what they mentioned in this study, So PPI inhibitor usage and risk of myocardial infarction, which has been combined in the general population by NIGA. So what I've been looking into this from, so what they're going to conclude from this study, there might be, as I discussed, the worsening of MI in general population, even in non-cardiac groups, is high possibility for this kind of patients who are going to subject the patient with PPI. So in this study, if you're going to look among 1.8 million population, 93% of GERD, 93,000 of GERD populations, most of them are being non-cardiac patients. So which shows almost more than 18 years of age group. It shows a significant impact of cardiovascular events, almost around 30,000 with your H2, PPI, which is almost around 12,000 only when you're going to use H2 receptor antagonist. So always, if you need to conclude, you need to assess once a patient is going to subject with your PPI, you need to analyze the patients properly, whether this kind of patients is having worsening of events is there or not. And next to that, this is what been taken from a BMJ. What are the major outcome measures the risk of the combined endpoint of cardiovascular death, myocardial infarction or stroke with use of PPI is going to get analyzed. And I didn't point out some evidence. If you're going to use PPI for a longer duration of therapy, longer duration of time, that shows some evidence of long-term dementia. Why dementia can develop? Because of your amyloid, which is going to get accumulated in your brain. That's how the Alzheimer's disease. So there might be around 30 to 40% possibility of worsening of Alzheimer's in the background of PPI, worsening of dementia in the background of PPI. There are so many other coexisting complications will happen if you're going to subject, and most of the time even the top consultants will be having difficulty in identifying this kind of presentation, whether it is mainly because of this molecule or because of any other coexisting present. So you should analyze the history, you should rule out all the possible pointers in order to come to the conclusion that this molecule is mainly because of PPI, this reaction is happening mainly because of PPI. That's the most important area for me to target with you all right now in the progression of discussion. So what is this study? What we mentioned there? So PPI and use of adverse cardiovascular event in aspirin-treated patients with first-time myocardial infarction. See, this has been a very interesting paper which has been taken from BMG. What they were mentioned in that, see, among all the PPIs, which is going to get compared, the pantoprazole, or lanzo, whatever PPIs we're going to get used, the hazard ratio is definitely going to be significantly high, and it's going to have a significant impact. And all proton pump inhibitors affects your gastric pH to roughly the same extent. The interaction between aspirin and these drugs is likely to represent a class of effect of proton pump inhibitor. That's what they've been mentioning in this diagram. Once the patient is going to subject, that might be having some interactions, and that's going to have a significant impact. It's going to inhibit your pathway in aspirin as well as clopidogrel. That might show the evidence that this patient is going to have a worsening of outcome if you're going to subject the patient with PPI for a longer duration of therapy. And this is what which has been taken from your European Art Journal, which what has been mentioned in this very interesting paper. Even after adjusting for your baseline variables and multivariate, and what I've been mentioning there, PPI use, as I discussed, in this paper, 50% high chances for the patients to go for a major cardiovascular events to set in by Stephen et al., which was taken from a European Art Journal group. So always you should be very careful when you're going to subject the patient with cardiovascular, once the patient is going to get subject with antithrombotic therapy. And this is what the most important area for me to discuss. So what is the pathway called? Why the patients with PPI, there is some possibility for these patients to progress myocardial infarction, nothing but ADMA pathways, nothing but what is going to, once a patient is going to get accumulated, if your ADMA activity, if nothing but asymmetrical dimethyl arginine, if your ADMA, if it is going to accumulate more, there is high possibility for you to get worsening of events because of this cardiovascular as well as because of the stroke-related mortality. There is possibility for this because once you're going to subject the patient with PPI, it shows evidence that this ADMA activity is going to go high. How? See, if you're going to look into this graph, this diagram, so mainly by the formation of L-arginine. See, As we all know, nitric oxide is a strong potential vasodilator for endothelial cells. What is going to happen once a ADMA activity, if it is going to go high, what is going to happen? The endothelial nitric oxide synthase activity levels is going to come down. Once the endothelial nitric oxide synthase levels is going to come down, the formation of nitric oxide is going to come down, followed by the vascular homeostasis will not going to get well maintained, and there is high possibility for this kind of patients to progress to major cardiovascular events, and major stroke and other complications can be reported. This the ADMA pathway of PPI. If you're going to look into this, the L-arginine, nitric oxide, citrulline, all those things is going to get blocked off because of PPI, which is going to get infrared, and the level of ADMA, which is going to get increased. When ADMA concentration increases, it directly decreases your endothelial nitric oxide, as I discussed with you, and thereby having a significant potential risk for this kind of patients to progress to a major acute coronary events. And this is what which has been taken from a recent art journal, this presentation. And apart from that, what I've been mentioning in this cardiovascular pharmacology, a combination of Clopidogrel and proton pump inhibitors increases a major adverse cardiovascular. If you're going to look into that, multiple drugs is going to get metabolized, as I discussed, COP2, C19, and 3A4 pathway. Among them, the clopidogrel is also one molecule. So what's going to happen? The blood thinning effect is going to come down. Vascular homeostasis is not going to be well maintained if you're going to subject the patient with PPI. And among the best of PPIs, rabiprazole can be reasonably considered, as I discussed with you, is mainly by the metabolism by a non-enzymatic degradation pathway. That might be showing some evidence if you're going to subject, but apart from that, the worsening of risk with MACE will be very high. When you're going to subject with PPIs. So among the PPI, lansoprazole is still in the top list for causing this kind of major, adverse cardiovascular events, and pantoprazole slightly lower down, and omeprazole is also in the higher list. So if you're going to, there are various combinations. Among them, chenotaprazole, the new molecule, also that shows some evidence because it's also being metabolized in an alternative pathway. That might be having some beneficial role when you're going to use chenotaprazole. But the most important thing, what we are going to consider, most of the PPIs will be having a significant impact in your cardiovascular strategy if you're going to maintain this kind of patients with longer duration of PPI. And as I discussed, the potential interaction between your PPI and your clopidogrel, it shows a significant increase in the rate of your GA bleeding. So clopidogrel may increase your risk of GA bleed. So we need to administer the patient with PPI. And I would like to point out, there are some papers on 2018 by, which has been taken from a gastroenterological association. What they mentioned in that shows evidence, even then if you're going to subject with clopidogrel PPI, we need to outweigh the benefit. So we can consider this patient with PPI for a longer duration of therapy in the background of in this kind of risk factors. But what I would like to state, most of the papers has been quoted like this. So clopidogrel worsening of events, the PPI should be used. PPI can be used only if you suspect evidence of GA bleed, but there is no much of pointers for GA bleed. Always you should think whether to consider PPI or not, because PPI only in limited resource situation, not for all the patients you need to subject. Apart from that, decreasing the clopidogrel inhibitory effect, as I discussed, clopidogrel is a prodrug that requires COP pathway to convert it to its active metabolite. So what is going to happen if you're going to look into this diagram? There are various things which is mainly being interacted, for example, with grapefruit, you want, and clopidogrel. If you're going to look all those things, the two major pathways, this, and what you're going to do, it's going to form an active platelet inhibitor. And once you're going to give your PPI, this pathway is going to get interact, your level of clopidogrel is going to come down, followed by, there might be having less chances for this kind of patients to have a significant impact to prevent your cardiovascular related complications. So always you should remember most of the molecules will be interacting through this in case of major acute cardiovascular, but that shows some evidence since rabiprazole can be considered as a minimal, with some minimal pointers to be looked into account when you're going to subject the patient with PPI. And this is clopidogrel and proton. This is another study taken from BMC, European Journal. So clopidogrel and proton pump inhibitor interaction, separate intake and non-omeprazole PPI, the solution. So what I mentioned in the slide, so the clopidogrel PPI interaction does not seem to be a PPI class effect, and rabiprazole did not affect the clopidogrel effect in a subject with the clear omeprazole clopidogrel interaction. So Always you should remember lansoprazole on the higher side, omeprazole next to that, and panto. And apart from these are still the lower molecules. And tenantoprazole and rabiprazole can be considered when you're going to use that. This is of the simplified diagrammatic approach. The most potent inhibition of your COP2C19 is by lanzo, as I discussed with you. Rabiprazole is the least potent. So this pathway, so there is possibility for the cytochrome, for your clopidogrel to have a reduced effect when you're going to use rabiprazole for a longer duration of time. So if you're going to look into this diagram, see, always see, this is how both the clopidogrel and PPI is going to get interact. So COP2C19 pathway, and this active metabolite of clopidogrel is going to get converted to its inactive metabolite by this PPI. That's why the interaction has to be very conscious when you're going to subject for a longer duration of time. So if the patient is going for a PCI intervention in the background of clopidogrel, or whether the patient can be subjected for new molecules like Enteric or all those things, what you're going to think about once the patient is having significant GA risk potential, where you need to assess whether the patient is having high risk or low risk. Once the patient is going to have a high risk, you better avoid omeprazole. You can consider either pancho or rabiprazole. But if the patient is going to have a low risk of GA potential in the background of clopidogrel, better to avoid PPIs. So don't give PPIs when you're going to subject the patient with clopidogrel if the patient is not having much of risk of GA bleed. GA bleed risk factors, as you all know, the patient has persistent reflux, previous history, endoscopic evidence, and shows evidence of coexisting other complications. So there are so many strategies to categorize whether the patient is having a risk factor for GA bleed, is that or not. Apart from that, for alternating molecules like ticagrelor or prasugrel, if you're going to look into the as well as GA bleeding risk, if you're having high risk of GA bleed, you can use any PPI. But once a PPI or once a patient, the risk for GA bleed is low, it's better to avoid PPI again, even in this kind of situation. So this is what been taken from another research from PubMed. What they mentioned that warfarin-induced raised INR is further prolonged by your PPI in pantoprazole. What they mentioned, so you already your INR. So most of the time when you're going to maintain a patient with anticoagulation therapy, your targeting INR will be around 2 to 3. It's the most important time for your INR to get targeted. But when you're going to use along with your pantoprazole, this INR may get raised and there might not be attaining a reasonable INR target when you're going to subject the patient with PPI therapy. So always you should analyze the patient to whom you are going to subject in background of thrombotic events. So most of the time when you're using a warfarin, INR ratio 1.5 to 2.5, most of the time will be the target for you to analyze these molecules. And incidence of drug interaction when using PPI with warfarin. What they mentioned is, see, if you're going to look into that, the group 1, if you're going to use lansoprazole, and group 2, if you're going to use rabiprazole, what they mentioned in the slide, the INR prolongation average maximum will be approximately 3 in case of, if you're going to subject with the warfarin groups and lansoprazole groups, and it will be around 2 when you're going to subject the patient around the rabiprazole group. So there might be slightly higher risk of progression of your INR when you're going to use lanzo when you compared to your rabiprazole. But this all the vascular hemostasis can be well mentioned, and apart from the major cardiovascular events can be well prevented. And incidence of drug interactions when using PPI with warfarin. What they mentioned in this study, see the overall INR, if it is going to be more than 3.5, it is going to be significantly higher in group 1 rather than group 2. Group 1, lanzo, it's being significantly higher rather than rabiprazole group. It shows a reasonable conclusion that if the patient is having evidence of high INR, better to go for a safer PPI rather than going for the same one. So why I would like to show this slide, the clopidogrel interaction, you should be very cautious. Warfarin, you can give any PPIs, and prasugrel, ticagrelor, you can give any amount of PPIs. But once a patient been subjected with this kind of COP pathway, you should be very cautious when you're going to prevent your major acute cardiovascular or renal injuries or stroke-related complications. Always you should target what are the primary area you need to manage. So what are the other concerns? What are the other things? This is only because of cardiovascular. There are so many other things to be concerned with. You're going to use. Briefly, we are going to look into that. So what is this? that shows some evidence of anemia. So what is going to happen if you're going to subject the patient with PPI, as most of the PPI is going to well absorbed in your small intestine? What is going to happen? The metabolic pathway of vitamin B12 is going to get happen in your small intestine. It's nothing but the most of the vitamin B12 will be absorbed in your terminal ileum. So once the absorption is going to get delayed, that shows some evidence of vitamin B12 deficiency that might be predisposing to your complications to get developed like anemia. And next to that, these kind of patients will be having coexisting other molecular, other complications like renal injury and other concepts that might be showing evidence of anemia. So always you should think that once a patient is going to have a proton pump inhibitors, that is associated with anemia in cardiovascular outpatient. So what they will conclude in this, use of PPI was associated with anemia, which has been studied from your Japanese population. So what was the background they have been taken? The PPI are frequently prescribed in combination with aspirin for preventing a peptic ulcer in patients with atherosclerotic disease. So long-term PPI has been suggested to be associated with iron of B12. The effect of PPI and hemoglobin concentration has not been clarified in the cardiac. See, that's what my main thing I want to discuss. Anemia risk factor potential will be slightly high in the background of cardiovascular coexisting morbidity. That shows some evidence if you're going to subject with PPI, that might be evidence that the patient is going over for worsening of anemia. And this is another thing which is want to quote from a recent paper. What they mentioned is that rhabdomyolysis, atorvastatin-induced rhabdomyolysis, an acute renal injury in a genetically predisposed patient with potential drug interaction. That's what. So a single nucleotide polymorphism is going to get developed if you're going to use your PPI. That might be showing evidence of worsening of rhabdomyolysis if the patient is having renal injury along with the atorvastatin therapy. So concomitant usage of pantoprazole could have resulted in this study, what they've proven, in the inhibition of COP450 pathway, and it's involved in the metabolism of atorvastatin, which may contribute for development of rhabdomyolysis. So be very cautious. Even for lipid lowering agents, when you're going to subject, you should be very cautious when you're going to subject the patient with PPI. What are the other issues to be concerned when you're going to use PPI? Multiple, so common things, hyperparathyroidism, which can happen if you're going to subject for a longer duration, around 3 to 6 months. Some patients, some evidence, some trials have been given in various papers because of independent of concurrent bisphosphonate therapy. What they mentioned earlier, that shows once a patient is going to subject for a longer duration, that shows some evidence that hyperparathyroidism may worsen when you're going to use a PPI for a longer duration, which is independent to your bisphosphonates. And apart from that, the most thing, another electrolyte disturbances, less hyponatremia, hypomagnesemia, so many other complications. How are you going to recognize your hypomagnesemia based upon your carpopedal spasm? How does it going to develop? Based upon your carpopedal spasm, other things which is going to get established. That shows evidence mainly because of PPI, because what the law is the serum magnesium concentration. So to the best of knowledge, what they implicate, the study, this is the first to show hypomagnesemia. This study has been done in a Japanese patients who are with cirrhotic background in the when you're going to subject the patient longer duration of PPI. So that's what I would like to say with you. Even for cirrhosis, usage of PPI is absolutely not much of indication. So better to go for H2 blockers rather than considering PPI, because PPI can worsen your PAMP and DAMP. That's where your gut dysbiosis can be predisposing. It will be affecting your gut metabolism, dysbiotic pathway, followed by your worsening of events of hepatic encephalopathy, or mainly because of spontaneous bacterial peritonitis. So many other things can supervene in the background of cirrhosis. So be very cautious when you're going to subject this PPI in the background of cirrhosis. That's a separate area for discussion. And apart from that, in the renal injury, in hemodialysis patient, what you're going to look into that. So magnesium concentration, the relationship is going to have a significant impact. So, and GI loss of magnesium likely to present in a substantial proportion of patients. So always may be considered as under-recognized entity. So always you should be very cautious in the background of renal injury and you're treating a patient with hypomagnesemia along with you're going to subject the patient with PPI. And next to that, what is the impact in your nutrients? So once you're going to say, if you're going to give your PPI for a longer duration, what is going to happen? There might be a significant impact. it may affect your B12 pathway, it may affect your multiple things, it may predispose to calcium absorption will be getting delayed, so many other things. Once the calcium pathway is going to get affected, that might be showing evidence of osteomalacia, osteoporotic changes, and because of osteoclast-like activity. Once you this PPI and bone injury, if you're going to look into that, once you're going to measure the patient with bone mineral density among in a ratio of around 4 weeks, 8 weeks, we are going to subject for BMD measurement, that shows evidence of significant loss of your BMD when you're going to subject the patient. But there are some trials which has been shown, even if you're going to use PPI for a longer duration, not much of varying effects in your bone mineral density assessment. But overall thing, what we are going to look into that, calcium metabolism is going to get affected and your magnesium pathway is going to get involved, followed by there is high possibility for you to develop a common fractures in various areas. Most commonly, that shows evidence of hip fracture may be reported if you're going to subject, but we are not very sure. We need more papers to document all those things to analyze. And apart from that, what are the various enteric infections? It's very common. Once a patient is going to subject with PPI, there might be a gut dysbiosis, which is gut microbiota, which is being considered as a new as brain, which is going to get perturbated, get involved, and followed by there is high possibility for you to have a worsening of this gut dysbiosis, and followed by there is high possibility for you to develop a various enteric infections. For example, SIBO, nothing but small intestinal bacterial overgrowth, can supervene. And once the patient is going to get SIBO, there are a huge list of molecules to target. It's a separate area to discuss, and you need to diagnose by lactulose or hydrogen breath. There's so many other molecules, so many other modality for you to diagnose the SIBO. And along with there is high possibility for you to have a worsening of Clostridium difficile infection, which is nothing but a predisposing factor for antibiotic-associated colitis. So this PPI can worsen once a patient is subjected to antibiotics or other line of therapy. You may have a worsening of events. Your antibiotic-associated colitis can worsen, and you have a Clostridium difficile infection can supervene. That's why my intention, always you should remember the pathogen-associated molecular pattern, the damage-associated molecular pattern, all those things to be well mentioned. It should not get damaged at any point of time. When you're going to subject the patient with PPI, it may have a significant impact in your gut microbiota, which will alter your proper eubiosis of your gut. So be very cautious when you're going to target your enteric infections, when you're going to subject the patient with proton pump inhibitors. And there are new and recent concerns by FDA mentioning about in cardiovascular that I want to be discussed with you: elderly population, fragile population, renal injured population. So always be very cautious. Use list of infractions, but common thing: major acute cardiovascular with Clopidogrel, and anemia with long-term PPI, hypomagnesemia on long-term PPI, and Clostridium difficile as have already been discussed, and possibility of renal injury in the form of either acute interstitial or tubular interstitial, or in the background of chronic kidney disease. Be very cautious to subject. And before concluding, what I would like to implicate, always you analyze the patient, to whom you're going to treat the patient, and how long you're going to subject the patient. Assess the weight, assess the sex, and based upon the ethnicity, based upon your genetic polymorphism, all those things should be taken into account, and based upon your metabolic parameters, with the patient's hypertensive, diabetes, or thyroid, or obese, based upon your BMI and all those things, based upon your hemodynamic status, based upon your based upon the clinical presentation, all those parameters to be analyzed properly, because subjecting PPI is easy, but tackling the complications of PPI is one of the most difficult tasks that we should not give aid for any of the patients to go to manage accordingly. So that's why that's the main area for me when you're going to subject the patient with longer duration, either for GERD or reflux or dyspepsia or Zollinger-Ellison, high dose of PPI, dual release therapy. Always you should remember that this high dose PPI regimen, dual release therapy regimen, there is high possibility for this kind of patients to go for a renal injury rather than going for a single dose regimen. So better focus on a single dose rather than going for a dual dose or something else, because the possibility of cardiovascular, your renal pathology will be slightly high when you're going for a dual dose regimen. So target all this thing, analyze the patient to overcome all the complications successfully. With this, I would like to rest my presentation. Thanking you all for patient listening, and I'm happy to take up your questions if anything is there to take on. Any questions for discussion?
Yeah, Dr. Shailesh, you are on mute. You are saying something, I think, but you are on mute, Dr. Shailesh. Yeah, the session is open. The house is open for the question answer. So any queries, any feedback, anything that doctors, you can unmute and you can ask the questions.
Yeah, thank you so much, sir. It was a very insightful session. And
Thank you.
sorry, I was on mute by the host. So thank you, sir. So we request all our panelists to share their questions if they have any question regarding to this session. So we have one question that since you have mentioned about ticagrelor, so what about newer agents like the interaction part? Can we follow the similar precautions with newer agent anticoagulants such as dabigatran and rivaroxaban?
Always we need to follow the same pathways, because even then dabigatran, if you're going to use a direct oral inhibitor, but even then you're going to subject with the patient with PPI, there might be having multiple drug interaction, which is going to be, and there are so many other trials needed to get proven all those things. Always when you're going to subject a patient in the background of cardiovascular events, the precaution what you're going to look into that is always most important. And also you need to consider the risk for GA bleed, and so the benefit should outweigh the risk. That's the most important thing when you're going to target this kind of patients with PPI therapy. Whatever the area of presentation, cardiovascular morbidity and mortality, there might be chances of slightly worse, slightly increased risk will be there when you're going to subject with PPI. But among the PPI, rabiprazole shows to have some least, some beneficial effect in this cardiovascular outcome scores.
Okay, so there is one question from Dr. Joffin John, particularly regarding the efficacy, which PPI is the best in terms of efficacy, sir?
As of now, the efficacy, which PPI is best, nothing much to compromise. As of now, the various studies, what we mentioned, esomeprazole has been having a reasonable potency in compared to other PPIs. Next to the rabiprazole, the efficacy is slightly high. Omeprazole is always less in the field. Pantoprazole, once we are going to give a dual dose regimen, that might be having slightly higher efficacy. But whatever the drugs we are going to use, a new molecule like chenotoprazole can be considered as a higher efficacy. But whatever the molecules we are going to get used, most thing you should remember that most of the drugs duration of action off-life will be around 1 to 2 hours. That's the most important thing. But the bioavailability will be varying, depends upon what are the various drugs we are going to use. And next to that, the metabolic pathway you need to forget. And apart from that, most metabolism will be by hepatic route. That should be strongly addressed. And when you're going to subject about the efficacy, as of now, the proven efficacy slightly higher. Nothing much of difference when compared to other PPIs, slightly higher with esomeprazole when compared to other molecules to be considered.
Okay, so there is another question regarding the what is your perspective on role of H2RA in current era of PPIs?
H2RAs is always one of the best of prototypes what we can consider, because H2 receptor antagonist, there is no much of adverse events when you're going to use for a longer duration of therapy, except for a few adverse events which is going to report even with the newer molecules like lafetidine or what are the molecules you're going to subject. The evidence of tachyphylaxis, the dose response phenomena, will be the only major adverse event if you're going to look for H2 receptor antagonists. But that shows some evidence of dementia, that shows some evidence of cardiovascular event, that shows some evidence of even your renal injury can happen because with your H2 blockers, but the potency, but the significance will be always less when compared to your PPI. So it's always better to go with H2 blockers to whomever it's possible for your best side. But once the patient is having worsening, see, if you're going to treat a reflex esophagitis of stage 1 and 2, it's okay. But once you're going for grade 3 and 4, possibility of PPA, we need to start. That's what I'm telling you. Analyze the patient properly before subjecting the patient with various regimens.
Okay, thank you, sir. Sir, apart from that, many studies have shown that long-term use of PPI is associated with a lot of adverse events like CVD, CKD. So, is there any definition how they have defined the long-term use, sir? So, any particular
So most of the trials, what they may mention, the long-term usage, if you are going to use for more than 6 to 12 months, but there are some papers, what they may mention, long-term usage for more around 3 months also. But most of the esophagitis healing process will be mainly by 8 to 12 weeks of regimen therapy. So once a patient there are some evidence. So renal injury, multiple papers being quoted. If you're going to use the patient for more than 1.5 years, 2 years. So 1.5 year, 1.5 to 2 years, if the patient is going to subject with the high dose of PPI regimen, that might be showing evidence of worsening of renal injury. But once you're going to get stop of your nephronic loss, everything gets, well, there is some possibility for it to revert back to a normal situation. That's why longer duration, it's not much of recommendations in the background of a simple gastrointestinal event.
Okay, so there is another question that since the now like the post-COVID era also, a lot of antifungals are being used for various fungal infections associated with the COVID. So is there any interaction with that you have seen with antifungal drugs with PPIs?
To be very frank, my experience with antifungals and PPIs is definitely very low, but what they may mention in the papers I can share with you all. See, if you're going to use azoles, if you're going to subject the patient with azoles-based therapy, that shows some evidence of COPD pathway infraction, like what we are going to use for your Clopidogrel and other things. That might be having a significant, might be having a minor impact when you're going to subject the patient with antifungal. Apart from that, antifungal itself is septicemic, I mean, worsening of even in the background of septicemia. So once a patient is having background of septicemia, immunocompromised, that shows evidence of complete gut dysbiosis. At that point of juncture, always you should be very cautious when you're going to use PPI, because there is some evidence that this is going to worsen because of this, and there might be evidence that the fungal infection can get proliferated because of this. So always you need to be very cautious to whom you're going to subject. That's the most important thing. That too in the background of septicemia, immunocompromised, to whom you're going to subject antifungal therapy.
Okay, thank you,
Not
sir,
for minor antifungals.
Okay, thank you, sir, for answering all the questions patiently. So there's last question. Sir, you mentioned about long-term usage. So in general, about your personal choice, how long generally do you prescribe PPI, sir, for a chronic patient? How long generally you prescribe?
So that's what I've been told with you. That's what I've been telling with you all. So the most important thing, to whom you're going to subject the PPI. So if you're going to treat a patient with Zollinger-Ellison, which is very uncommon scenario, not frequently you'll be encountering, but if you're going to treat for a Zollinger-Ellison, we need to give a higher dose of PPI regimen, no other go, because the secretin pathway, everything is going to get very high. So you need to target that. So you need to have a prolonged duration of therapy. And next to that, if you're going to suppose if your endoscopic finding doesn't yield much, a non-erosive esophagitis or grade 1 to 2 esophagitis, if you're going to target minor duration, I mean 8 to 12 weeks of regimen is well and good. Some patients may be needed around 12 to 24 weeks of therapy based upon the clinical presentation response. Always PPI is one molecule can be considered in the management armamentarium, but it's not the only molecule to be targeted in gastroenterology practices.
Okay, thank you so much, sir. Any other question? Jayesh, any other question from the panelist?
Yeah, just if any question is there, doctors, you can now unmute and you can ask the questions.
Pencil box.
Keep this asking you a question, I think so.
Yeah. If there is no question further, I just hand over the session to our stated Mr. Arun. Yeah, Arunji, over to you.
Yeah, good evening once again, sir. I'm Arun Kumar, the Senior Regional Sales Manager on behalf of Lupin. I'm wishing you all happy Doctors' Day, and thank you all for your wonderful participation in this RTM. It was a very interactive session, and we got a lot of understanding on the inside story of PPI. I thank Dr. Arun sir for sparing his time for his busy schedule and addressing the group. Thank you, sir. I also thank Imagica team for providing technical support for discussion. Doctors, we express our gratitude and salute you and entire medical fraternity for fighting against COVID-19. and providing us confidence in this pandemic situation. You are our real heroes, superheroes. Being a reputed pharma company, Lupin is always there with you in this fight. Please do connect with our local field staff for any help. This is all from my side. Have a pleasant evening to all. Stay safe, stay protected. Thank you, sir. Thank you.
Thank you all for organizing this event. Thank you very much.
Thank you, sir.
all.
Thank you. Thank you. Good day, sir.
Thank you, sir. So can I end the meeting?
Yeah, please end the meeting. Yeah, thank you.
Okay, sir. Thank you.